everyone for joining us again. I'm sorry about that. Always happening, these things. So I'm Timur. I'm leading the product at Agamon. And we're working with major healthcare organizations, both in the US and in Europe. While we're doing it as part of our philosophy, we've developed our technology and product together with the industry in collaboration with our partners. And because of that, we're coming across many individuals that are knowledgeable in the field. And we always get a lot from them. And this is why we decided to host this webinar. We thought that you will be able and will be happy to hear from them as well. And for this particular webinar, we chose two brilliant partners of ours. So we have here together with us today, Professor Lincoln Berland. Dr. Lincoln Berland is a professor of radiology at University of Alabama at Birmingham. He has dedicated about 140 research papers, one book, and 45 years to the field of radiology, and founded the ACR Incidental Finding Committee. And we also have here Dr. Lawrence Tenenbaum, who's the Chief Technology Officer, Director of Advanced Imaging, and Vice President of RadNet. His focused areas include applied artificial intelligence, advanced medical imaging, and diagnostic imaging. So, Dr. Tenenbaum, the stage is all yours. Feel free to share your deck, and we can start.
Wonderful. Give that a shot. Tim, why don't you smile when you can see my pictures?
I can see it.
Okay, wonderful.
Great.
So I have the privilege of opening this program and the honor of speaking side by side with Dr. Berland. I will do a lot of introductory things and set the stage, and Dr. Berland will dig in deep, and we will all enjoy his erudition. Let me see if I can make my slides advance. Okay, so I'm going to do a bit of an overview of what is AI, where AI fits into society, and then we'll do a deeper dive on where AI is in the imaging enterprise. And then I'll introduce the concept of NLP, NLU, natural language processing and understanding, and talk about areas where it has shown some promise or actual functionality in the radiology enterprise in a relatively superficial fashion for the next 19 minutes or so. So what is AI? AI is essentially a branch of computer science that lets machines do things that we associate with human capabilities: sensing, comprehending, and learning. This capability is all around us. We all know that wherever we go, we know exactly what we bought online. We know how the traffic is working on the highway, all the things that are going on with AI. We're very familiar with autonomous driving, which is a direct effect of computer vision. And we're also familiar with the great achievements that AI has made in terms of beating champions at complex games like Go and chess. At this point, we already know that the computers are better at image recognition than humans are. We also know that computers are better at speech recognition than humans are. So things look very, very positive and very, very exciting, and maybe even a little threatening when it comes to what AI can do. But in reality, AI has its distinct limits and distinct capabilities. In general, things that humans find hard, looking through jillions of data, looking for patterns in a complex environment, very hard for us to do, very easy for computers to do. On the other hand, things that we find very easy, recognizing someone walking across the room, picking up a pencil, understanding context, very, very hard for AI to do. So despite all of the great capabilities that you've already seen, and you're probably more than aware of, there are still some challenges. Robots don't do really well in complex environments, even they look really good in a demo. Driverless cars don't really work well on their own. Well, they work until they don't work. Humans need to be involved. Even though computers do a great job with text in general, they don't really function at a very high reading level. And frankly, the fundamental limitation can be seen in looking at complex visual scenes. When we look at this picture, we know something's weird. I mean, I can just feel it, even looking at it now. The computer won't. The computer sees a rock, it sees dirt, it sees a sky. It doesn't understand that something's off here. And it certainly doesn't understand that this is actually a picture that's upside down. It's actually a rock in water, and that's all reflection. So a key limitation of a computer. I like these examples as well. It does a great job knowing what a bicycle is. It knows what grass is. It knows what clouds are, but it doesn't understand why the clouds are next to the wheels and why the seat is next to the grass. You know, better seen in this case. Here you see a duck. I hope you can see. I hope it's not blocked by my box. You see a duck on a roof watching TV. All things that computer vision can recognize, but it doesn't recognize that it's really odd for a duck to be watching TV, let alone on a roof. So the contextual piece is really where computers fall down. And computer vision is pretty remarkable. It does an amazing job telling Dalmatians from ice cream, chocolate chip ice cream, but you know, it occasionally makes catastrophic errors like calling a blueberry muffin a chihuahua. And as you've seen so far, there are limits to what it can do and mistakes can be made. Like, you know, self-driving cars crashing, or the need for humans to override autopilot and save these folks just outside my window in New York City. So in general, despite the capabilities of computers, human involvement is still essential in a number of different ways, particularly when context matters. And we see this at Facebook, at Google, at Twitter, at the largest financial institutions, even in China. Actually, my favorite illustrations in the right-hand corner, these things were flying all over poles in LA. And you know, someone who had this huge campaign to celebrate this huge grant, but no one involved knew that a brain is supposed to point in the other direction. And as you can see from these pictures, the brain is in there backwards. So getting to where AI is in the healthcare enterprise, you can see from this chart between big data analytics and AI, it's really where the greatest expenditures are going on. You see that healthcare funding continues to go up in this space. And you see that some of the biggest OEMs in our imaging space are all getting very, very involved with patents and investments. There are a lot of companies working out there in the AI space. As you can see, there's an awful lot of investment and it's projected to continue to go on. You can see the applications that are really going on out there. A lot of it's being done in diagnostic, the ability to do computer-assisted diagnosis, you know, leveraged by deep learning. Some of it is in quantitative work, and some of it is dealing with, you know, automating repetitive tasks. This little piece here, explorative, is kind of interesting because this is where you show the image, you show the computer a pattern or a lesion, and it will bring up comparison patterns and lesions for you to interpret and associate, which I think is really interesting. So there's a lot of areas where AI is, there are a lot of capabilities of AI. The one we're going to concentrate today for the next 15 minutes or so is in the area of natural language processing. So what is natural language processing and understanding? It's a technique that aids in the conversion of text into a structured representation. In this case, structured in the way it does its analysis rather than structured reporting, so to speak. It enables computers to get meaning from natural language input from a human. There are lots of opportunities in the healthcare enterprise. When you look at where patients come and see their doctors in terms of the history and physical, the doctor then creates an image request which goes to the RIS. The technologist reads the RIS and prepares a protocol, you know, for the patient's actual scan. The actual scan goes on and it gets back to the radiologist. The radiologist interprets that examination, makes a certain recommendation, it goes back to the physician, who then makes a decision for the patient. Seems straightforward. We do this every day. Problem is, there's lots of opportunities for failure here. And these are opportunities where natural language processing and understanding can make a difference. We really have very poor utilization management, and NLP can make an impact here by reading the history and reading the chart, and even some genomics, and saying this is the better exam for the patient. We have inconsistent protocol selection, and NLP can assist in choosing a protocol that may be best for the patient. We have variable execution of the imaging acquisition. Maybe we did the wrong protocol. Maybe we had variable image quality. And we have limitations in terms of coding, in terms of image review and the like. So lots of opportunities for AI to make a difference in and natural language processing to make a difference, including perceptual errors beforehand. So this is a spectrum of where AI makes a difference in radiology. And if we focus on where the natural language processing come in, you can see it's a lot of areas, from clinical decision support to assisting in scheduling, to picking the acquisition, to actually assisting in the diagnosis based on what we know about the history, to even adjusting reports and following up on reports, all in the area where natural language processing can make a difference. And when we use these tools in medical records, we can actually extract the information and do automatic identification that can really streamline this process. So natural language processing is capable of reading a report, reading free text report, and pulling things out like the history, imaging findings in the current report, as well as prior reports, and even follow-up recommendations. This can actually be used to inform things like utilization management that I mentioned before, or some people call clinical decision support. It can actually impact on the protocol that you use, optimizing that protocol, taking humans out of the loop and allowing them to devote more time to things that deliver more value. It can improve the pertinence of the examination. How many times have we done the wrong exam for a patient's history because we didn't have enough information? If this tool could read that history and prep us as to why the patient's there, we can increase the value of that examination. And of course, if we increase the value of the exam, we get reduced callbacks. If we do that, we get better patient satisfaction and better referrer satisfaction. Natural language processing can also read the report, flagging and classifying findings to make sure the coding process is correct, allowing us to use fewer coders and improve the overall concordance of the report and the coding and the accuracy of the code of the report and the coding. It can also assist in peer learning and review by looking at the exams and comparing what it sees with what the report says and making and improving that process. It can also focus, flag and classify findings in the prior reports so that the radiologist knows why the patient's here and what the key pertinent positives and negatives of this episode of care really are. And you know, if you're a radiologist, you know when these processes fail. It can also, in conjunction with computer vision, compare what you're saying in your report with what the computer-aided diagnosis or computer vision is seeing, allowing it to avoid critical omissions, saying things like, by the way, I've read your report and you left this out. And as you can see, by doing that prospectively rather than retrospectively, this is a way to improve quality. And frankly, you might get nervous when you see this type of capability because you might think it would lead to flagging of a million different abnormalities that you've already seen. You know, we had some of this in the early days with CAD, particularly in breast, but the modern tools can actually read your report and read the images and then say, hey, you know, I'm not going to bother you with the ones that are in your report. I'm only going to talk to you or alert you to the ones that are not in your report, giving you the benefit of a second reader on your shoulder, but mitigating alert fatigue. As an example, you know, it can actually see that liver lesion with computer vision and read your report and say that you didn't call it and let you know before you finalize the report, before it goes in the medical record, that there's something there for you to do. As a matter of fact, this is a paper that I participated in that actually looked at that unique capability of NLP and computer vision in looking at high-risk lung screening or low-dose lung screening. And it would simply do what it, you know, as I said, it would look at the nodules in the exam, read your report, and only alert you to the ones that you didn't mention, or in the cases, or in actuality, only alert you to the cases where you didn't identify nodules, you wouldn't suggest follow-up, and it would say to you, hey, bud, you should take another look because we see some other things and here they are. You may want to include those in your report. Really kind of a cool and very impactful capability as far as I'm concerned. Now, the same synergy of computer vision and NLP can be used to go through cases and become a more efficient and more all-encompassing peer review and learning circumstance. This can be done, or it can actually be done prospectively, where that little, you know, angel is sitting on your shoulder, you know, doing that peer review, saying, you know what, there's something else here for you to see in this particular case. Now, one of the areas that I think is probably the most compelling for NLP in radiology is in looking at follow-up recommendations. It can read your reports, identify follow-up recommendations, automate, be part of the process that automates that follow-up, and be part of the process that innately standardizes that follow-up process. It has been shown that, you know, this is some work that Agamon has done. They looked at 3 million reports, and they found that 32% of the follow-up recommendations in the reports were not, 32% of the cases had follow-up recommendations. And of those, about half of them were never completed. Imagine you had a tool that would watch over your operation, that would look for those recommendations and be able to be part of a process that identified whether the patients came back for follow-up or not. This type of data mining and follow-up can have a huge impact. Our organization, RadNet, has worked with a company called White Rabbit that had this functionality in mammography. And they showed that they were able to create a 25 to 50% increase in year-to-year volume just by identifying cases that need follow-up and becoming part of a process that ensures the follow-up. And that's a really cool thing. The other thing that's really important in terms of radiology follow-up is the inconsistency and lack of standardization in what radiologists put into their reports. We find in any given practice, there will be variable recommendation patterns, despite the fact that there are evidence-based guidelines that are widely known. This leads to inconsistent quality. It leads to a high level of irritation to referring physicians. When one radiologist sees a 4mm nodule and says X, another radiologist sees a 4mm nodule and says something completely different. And frankly, as a quality move, the payers are starting to realize that this capability is there. They're also becoming very aware that the practices that follow evidence-based guidelines are delivering a better product and may very well be willing to pony up an extra 1% or so to those practices that have these better approaches to these types of follow-up recommendations. There's no question that if you use these tools to improve compliance and standardization, quality will go up, your referrers will appreciate that and become more loyal, and may eventually be valued, if not even right now, be valued by payers. Now, again, natural language processing lives naturally in the report space. There are some challenges in the reporting space that we really haven't dealt with, right? Patients want access to the reports immediately and after it's released, and additional, basically they want access soon, okay? Even when there is abnormal results in the report, patients want to see the results in a timely fashion. Waiting for results leads to anxiety in 45% of people. It's really not a pleasant thing waiting to find out if there's something sinister waiting you when that report gets read. And it takes a while for providers to read an exam. Okay, even though radiologists have really worked on turnaround time and may get this done within hours, it takes days before a referrer actually will acknowledge, register, and take the time to report that back to a patient. We know that the 21st Century Cures Act has really raised the bar in terms of what we are obliged to do with reporting. We are expected to allow patients rapid and ready access to their data and make it intelligible to them so that they really can leverage the value of this data. It is incumbent on us in the radiology community to be accountable for the content, readability, and quality of our reports. Natural language processing and natural understanding can be part of a process that transforms complex radiology reports, which may have been written for a neurosurgeon, into a patient-friendly format, empowering patients to take control over their health, allowing them to become more involved in decision-making, in increasing their satisfaction with the medical imaging process, and this is always important, increasing their loyalty to our imaging facilities and the ones that actually deliver this service more than they do, again, for others who don't. Again, this is all part of patient-focused care, ensuring that patients understand the meaning of the reports that we give them. And natural language processing can actually create, in an automated fashion, a summary in lay language at the end of a report that assists in their ability to understand and integrate the information inside. Now, the last thing I want to talk about is the fact that these tools can be used to auto-generate reports. When you combine these with computer vision, which can detect lesions, it can actually pre-populate a report. There's just an example from Icometrics where the computer analysis is both detected lesions and quantified lesions, and it is, in a relatively rudimentary way, pre-populating the report with those findings. So the human radiologist doesn't need to dictate these individual pieces, doesn't take the chance of erroneously transcribing those individual measurements, and this can be done automatically. This is relatively rudimentary, but it is a valuable tool to get done. At the other end of the spectrum are tools like this one from Colombo, where not only does the software identify herniations, vertebral compression fractures, misalignment, but actually takes all the information that it's got and directly pre-populates that. Actually, it doesn't pre-populate it, it creates a genuine free text report from that CAD data. And you can see the value of that as well in terms of streamlining processing, as well as streamlining standardization, because the reports will all come out once customized in a very similar and standardized way. So I've taken about 18, 19 minutes to sort of lay out the landscape where natural language processing fits into the imaging enterprise. Here you see the reading radiologist with a little computer vision here and NLP, helping the whole process go through. I hope this was a reasonable introduction to what the possibilities are out there in the imaging enterprise, and I look forward to Dr. Berlin's more erudite presentation to follow. Thank you very much for your attention.
Thank you, Dr. Tenenbaum. And we now have Dr. Berland, and just before you're sharing your screen, you can go ahead and share it. I just want to remind everyone that you can feel free to start sending us questions using the Q&A button, and then we'll leave some time to it at the end.
Okay, well, thank you. You all see my screen, I assume. So I want to talk about a different perspective here, and the perspective I'm going to talk about this from is basically what the patients expect of us, and how well do we and can we fulfill the patient's expectations. Now, these are the kinds of things, this is a list that we won't go through. I've highlighted in blue the kinds of things I'm going to spend more time on. One thing I'd like to mention, and of course, Dr. Tannenbaum's excellent presentation, he covered a number of these things. But in the middle one, communicating information, we should appreciate the report is truly the only systematic method we have of communicating and consulting with the referring provider and the patient on their plan. Everything else is sort of ad hoc or differs from one institution or one situation to another. So we're going to talk about the management of applicable medical knowledge, which is frankly hopelessly complex, and talk about prioritizing urgency, importance, making recommendations, and acting on our recommendations and following them up. Now, as Dr. Tannenbaum mentioned, a number of years ago, back in 2006, we started the Incidental Findings Committee in the American College of Radiology. These are just a sampling of about 15 papers that have been written since that time that address how to manage all sorts of different kinds of organ systems in the abdomen, pelvis. We have a pituitary, a thyroid, et cetera, et cetera. These are not the, I've been involved, these are the things I'm most familiar with. There are lots of other kinds of systems that are available that have organized information with guidelines and recommendations. And for example, the report and data systems, RADs like BI-RADs, PI-RADs for the prostate, TI-RADs for thyroid, et cetera, et cetera. Actionable findings papers. There are innumerable types of systems that provide organized information about how to manage patients. Now, in these incidental findings papers have included, all of them have included charts and flow charts such as this, and I'm not trying to go over the details of this, but what you can see from these charts is that the yellow boxes represent information steps in the process. The green boxes are action steps, and the red boxes indicate that you've terminated management or diagnostic workup in a patient. Now, again, not to talk about any of these details, but the point is that there are numerous such workflow assistants, and it's humanly impossible to try to keep these in your head or act upon them from memory. we have to have some sort of reference or computer assistance. Now here, I want to show you a slide created from a paper from a number of colleagues at Mass General. And what this shows in discussing abdominal CT incidental pulmonary nodules is that when you have the guidelines present, but you're not using a system that automatically provides that information for you in workflow as you're interpreting the case, the compliance may be on average about 45%. If you create a computerized decision support system to assist that, you can increase that to 95%. This is one particular instance. There are innumerable instances throughout radiology and medicine that show that assistance at the point of interpretation can be enormously helpful for improving guideline compliance. Now, when do we need help? Now, all the time, but basically any condition requiring a follow-up examination or procedure. Screening examinations are particularly crucial where findings need to be followed up. Incidental findings, as we've talked about in almost any environment. Emergency department is a particular focus because these patients come in with one particular problem that needs to be dealt with emergently. And if they have incidental findings, you have to have a system to follow those up. And that's commonly a reason that incidental findings do not get followed up. They're identified in an emergency department environment, and then they are not followed up. We simply can't always remember what to do, when to check if it got done, and to document thoroughly and accurately. And of course, computers and particularly natural language processing can help us do that. So what is the scope of this problem? We've talked about that. Dr. Tannenbaum addressed that somewhat. I just want to highlight one study. Again, there are a number of different results, but they all have similar findings. In this study of 7,000 patients, 13% ended up with recommendations. A third of those were not followed. 39% of those that were not followed, there was not even any documentation that the recommendation was recognized or acknowledged by the referring physician. And 32% of those 39% had important findings, 18 mass lesions, 2 fetal deaths. Obviously, this is a significant problem. Now, 80% of healthcare data is unstructured. 29 to 77%, on average 50% of radiological follow-up recommendations are not completed. 25% of radiologists in the US get entangled in at least one communication-related lawsuit. And as Dr. Tannenbaum discussed, radiology reports are very hard for patients to understand, and there's increasing demand for them to read those virtually immediately, especially by the CARES Act. Structured reporting. I want to talk about several experimental efforts to try to close the loop where recommendations are followed and then followed up on again. Structured reporting exists, but it does require some fastidious report organization. Now, because of the need to generate this structure, which can be extremely time-consuming and difficult and involve teams of people, it's not widely accepted or implemented, even frankly, in those institutions that have done a pretty good job of developing structured reports for specialty examinations, or even in general, where everything is labeled in terms of the organ system and the particular finding. Even then, it's not always used. So lots of people have been attempting to refine structured reporting for decades. They've had some success, but limited success. I don't want to make you think that I disapprove of structured reporting. I think it's extremely useful. It's just really hard. It can be extremely helpful, but solutions are often spotty. They're local. They're not transferable from one institution to another, or even from one section of a department to another. They're not scalable. And if they're going to persist, they require a lot of ongoing attention. So they are not the final answer to the question of closing the loop. So as far as computer solutions go, where should we focus? Now, certainly current solutions, prior solutions focus on the radiology information system, PACS, and the electronic health record. But these are not systems that are designed and optimized to help close the loop. Sending an alert is something that's increased, but is not enough. And often, as Dr. Tannenbaum mentioned, can lead to alert fatigue if they're not well designed. Some have designed checkboxes for radiologists to note where an information about a patient is sent to a nurse and even a specialist to review to see if their recommendation is reasonable, but even that is not enough. So some dedicated processes to assure follow-up are clearly needed. What about NLP, as Dr. Tannenbaum extensively discussed? Now, the difference with NLP is that it can be universally applied, while primary systems cannot, no matter how sophisticated they are. Providers may miss or not act upon recommendations that are not in the impression or recommendation section. That's not a problem with NLP. They can accommodate structured reporting or free text reports or a combination thereof. And we know NLP will evolve, its technology will improve, and it can learn from errors. And it should be used with structured reporting. I don't want to underemphasize the fact that some human component to how findings are managed and recommendations are followed is really an important requirement of how this happens. So what are the challenges for natural language processing? Well, when people dictate in free text, they may not be clear. And if you're talking about vocabulary, there's a vocabulary of certainty, how certain the radiologist is in the finding, but it's, despite numerous people's efforts, it's truly not standardized. And how confident one is in the recommendation is also not standardized. Also, once you have a finding that knows that you need to do or you need to follow, who do you talk to? How urgent is it? How important is it? One study showed that if two providers are contacted with the same follow-up information, it may actually decrease the chance of follow-up because each expects the other to act. So you have to get collaboration interdisciplinary between radiologists and referring providers. The provider, we have to know whether the provider agrees with the recommendation, and we have to know what mode of communication they particularly prefer, fits in with their own workflow, and how to arrange and schedule the examinations. We need that collaboration. Now, this is one screen from one attempted solution at Brigham and Women's. And what it shows is that they created a formal way to extract information on the recommendation and ask the referring provider how they want it to be handled. Should radiology do the scheduling? Will they do the scheduling? Do they not agree with the recommendation? How would they like to modify it, et cetera, et cetera? All of these are critically important things to inform how the patient should be managed. Dr. Ben Wandke has done a lot of work in this issue of closing the loop, and he has established this system where it's a multi-stage tracking system where after a certain period of time, it's determined whether a recommendation was followed. And again, if a month later it's not done, there's another alert sent. They determine who does the calling and who is called, and it escalates to the point where if nothing happens, it may involve directly sending a letter to the patient. He further then, after this initial work, implemented a multi-stage tracking system with NLP. 43% initially prior to LLP, the recommended examinations were completed. Following implementation of the multi-stage tracking system I just illustrated, it increased over 70%. It increased further when they added natural language processing to identify those cases where recommendations occurred that were initially missed by a more manual system. Now, Dr. Tannenbaum also talked briefly about the fact that we need to be accountable. There are embryonic efforts to force healthcare to close the loop, not just to support them in closing the loop, but the payers, as was talked about, may prefer if you have a system that does that. But there's a law in Pennsylvania now that requires diagnostic imaging facilities to directly notify outpatients about the imaging examination with significant findings. Now, there are also metrics that are being developed, for example, CMS, I'll illustrate in the next slide, with regard to, for example, the rate of patients receiving recommended follow-up care and getting appropriate guideline concordant care, and it may include a checklist. So, for example, this is a draft from the ACR to propose to CMS how these kinds of things might be done. with the measure description being the percentage of patients with at least one actionable incidental finding who received follow-up imaging within the recommended time interval. Now, this is the kind of thing that's likely to be adopted at various levels of government that are going to make sure that we're towing the line and doing what needs to be done for the patients. So in summary, determining appropriate recommendations, communicating, following up are done really at unacceptably low rates, and we've been getting away with that essentially forever. Multiple attempted solutions may be locally successful, but are usually not transferable, scalable, or persistent. NLP offers the opportunity for a universal application to identify cases and to help assure follow-up, but numerous challenges persist regarding how alerts are communicated, who does that, and how to escalate the attention when recommendations are not followed. Regulation and oversight are appearing, and healthcare's poor performance should not and will not be tolerated permanently. Here's a list of references. If you get a copy of this, you can refer to these if you want to get into more depth about any of these topics. So thank you for your attention, and I look forward to questions.
Thank you. Thank you, Dr. Berland. So we'll go into questions just after my part, which will finalize this fascinating discussion. Okay, so just like, how are we, just about us, a bit about Agamon and how we took all of what you just heard now and what we decided to do with it. So we've built this company 3 years ago with the goal of taking this 80% of unstructured healthcare data that Dr. Berland just mentioned and do something with it. So we believe the data is the key to better decision, the key to better solution, and the key to better care. And like Dr. Tenenbaum and Dr. Berland just presented, AI and NLP technology and solutions can really utilize this data, structure it, and then create something with it. So this is what we do. We decided to develop these technologies. We developed our own natural language processing technology and deep learning understanding, and started to go over radiology reports. So now that we had this amazing technology, we ask ourselves, okay, what can we do now? How can we bring value today to our partners, to the healthcare organization that we're working with, and the radiology practices? And in order to answer this question, we took this amazing technology and decided to dive into this data and to go and see what's there. And just like Dr. Tenenbaum mentioned, what we saw, the first thing that we saw was that 55% of patients that have follow-up recommendation in their radiology reports actually do not follow up. It means that 1 out of 2 patients that have an abnormality, that have a certain findings, do not follow up on their treatment, on their procedures, and on their care. And there we had a problem, and we decided to build a solution to this exact problem using our technology that we've developed. And we knew very early at this stage that it's not only taking this natural language processing and structuring the report, extracting the recommendation, it's not enough. In order to this solution to really bring value, will need it to be an end-to-end solution, and this is exactly what we've developed. We developed an end-to-end solution, completely customizable, as automated as possible, to really try and solve this problem. And this is what we're working on with our partners today in the US and in Europe. So a few things that were very important to us while thinking of this solution and building it was that the first one, simple integration. So we know our partners, we know IT burden, we know that time is money and it really matters. So we put a lot of effort on that to make this integration with our partners as easy as possible, fast as possible. We're taking everything on us. Then to have the best models, to have high accuracy. So this is what we're doing with our AI and NLP, the automated data extraction, we then extract, after integrating with the system, we then extract the key element, the key finding, the follow-up recommendation, the time frame, the time interval from the report, and then to provide our partners with a system to help them manage it all. And we have this system, it's called Agamon Coordinate. Agamon Coordinate is our management platform. With this, our partners are communicating, managing, and tracking radiology follow-up in a very easy and seamless way. And I think that with that, we can go to Q&A. And now that you've heard all of this discussion, we will all be more than happy to take the questions. But I think that I need to stop the screen sharing and you can see us all. And let's see. Okay, we have here some questions. Okay. Okay, so first question. Do you apply NLP or NLU at the front end or at the back end of your system? So I think that this question is probably for me. So yeah, we're sitting after the radiologist is signing the report, after the radiologist is dictating the report, and we then apply our NLP solution. So like I mentioned, we'll integrate into the RIS or the PACS, wherever the reports are stored. We'll then take these reports, we'll use our technology on it, we'll extract the key finding, and in our management dashboard, we will manage all of these recommendations. I hope that this answers your question. Let's see. Okay. We have another question here. 1 second. Okay, which RIS or PAC systems do you integrate with currently? So with our existing partners, so we can integrate with any RIS or PAC system. With our existing partners have Epic, Radiant RIS, they have Fuji RIS, yeah. So Epic, Radiant, Fuji, and all of the others. Once you integrate with Epic, you can integrate with all of them, I guess. Okay. Okay, we have one here. I work for a medium-sized hospital that developed a system to help with follow-up. It is time consuming. Do you think that NLP could solve this? Okay, I think that we just answered this question. Maybe Dr. Tenenbaum or Dr. Berland, I would be happy to hear your thoughts about, so this, I think that this question may be open and other questions to how much of this solution do you think can be automated comparing to how much human involvement is needed? So I know our view, but I'm curious to hear yours. Maybe you have. Dr. Tenenbaum, you're on mute.
I don't see Lincoln jumping on this. I'll quickly stick my 2 cents in. We all have processes that are devoted to bringing people back for follow-ups because of the issues that I highlighted earlier. But they're just not really all that good. And we were challenged by a provider in this space to give them a shot to see if they could improve this process and make it cost effective. And they showed that they were able to substantially, I mean, just formidably increase the compliance rate for people returning for their screening and diagnostic mammograms simply by using their automated, their process, which was a combination of automated and I think human involvement. So all of these processes that I talked about today will benefit from the automation, the standardization, and higher level of efficiency that artificial intelligence, computerized capabilities can bring to bear.
I would just add, sometimes it's simpler solutions can work. I just saw an article recently that noted that automated phone calls to patients who are no-shows or in advance of their appointment can be as effective as a personal phone call, which is obviously more labor intensive. So understanding that there are various ways to contact the patient to make sure that they follow up. And it's also important, as I highlighted, that you have to know what the doctor wants you to do. And radiologists can help perform a lot of those functions at a clerical level without radiologist involvement. Sometimes a radiologist does need to be involved, but you need to give it some thought, and you need to, the fact is, of course, a radiologist is the doctor's doctor, and they deal with so many different specialties that each have their own systems. So you have to know how each type of physician is going to accept the information and how willing they are to do it, and whether they agree or not with the recommendation. And if they don't, you have to accommodate that. So it does require some human intervention, but NLP and AI can be enormously helpful to automate that process to make it more efficient and more accurate.
Yeah, great, thank you for that. And I think that what you just said leads me to another question that I see here. So who do you think should be the responsible for making sure patients are actually following up on the recommendation? So yeah, I know that we're hearing this question a lot, right? Should it be the radiologist or the referring physician? What's your idea of that?
Well, I know that radiologists, I know that referring physicians can be very irritated about too many recommendations. And I think it can be a tremendous service that the radiologist or the radiology system can provide to the referring physician and the patient to take an active role in making sure that the patient comes back for an examination that the referring physician agrees should be done. So I think it's very reasonable for the radiology department to take some responsibility for scheduling patients. It has to be scheduled through radiology anyway. If the referrer refers that right back to the radiology department, this radiology department should have some system for making that schedule and informing the patient that they need to come at a particular time and to follow up with a reminder.
I agree with Dr. Berland. Lots of different players share the responsibility, but there's no question that once a radiologist has identified something and made a recommendation, that they have some degree of obligation to follow through, and they can be faulted in a medical legal setting if they don't.
Okay. And what do you think about communicating directly to the patient and not to the referring physician, just to leave them out of this?
You know, it's an interesting thing, because I grew up in an environment that said, don't make recommendations because it irritates the referring physicians. You know, don't follow up, you know, and I've been in the courtroom and said, look, I can't expect radiologists to recommend the next step, because again, it's not the way that that medicine works. The referring physicians generally resent when we make these types of suggestions. On the other hand, you can see that through changes in society, through changes in the regulatory environment, we are being specifically tasked to communicate in a way that patients can understand and act on the information that we provide. So I actually think that direct communication is increasing, particularly in certain areas where we have the primary responsibility, like, you know, women's health and mammography and the like, where patients may not even have a referring physician, being a screening examination. And, you know, we're really the only physician in the loop.
And I would add that in a number of situations, particularly as an example, incidental findings, the radiologist is considerably more knowledgeable about the true importance of what an incidental finding is than the referring physician is generally. So having the opportunity for a patient to talk directly to a radiologist about that finding can be very useful. I do think that the referring physician at some point needs to be involved, and we can't just go ahead and make a recommendation and schedule a patient for an examination unless the referring physician understands that we're going to do that or agrees that we should do that. So it makes it a little more awkward, but radiologist has a tremendous amount of, and people don't appreciate how much general medical knowledge radiologists have, in addition to specific imaging knowledge about incidental findings and a number of other findings.
Yeah, we're seeing together with our partners, we're seeing like different approaches. So we have some that will say communicate only to the referring physician. You know, we don't want to step on their toes, but we have others that now starting to really, I think it's going also with alignment with the ACR committee, probably with Act 112 in Pennsylvania. Like there's a trend to really put the patient in the center. So I think that this will go even further with the patient portals as well. Hoping the adoption will increase. The communication will probably be to the patient in the future more and more. But I guess we'll have to see. So because we don't want to, we want to stick into the time and to the plan because we really appreciate all of your time. I want to thank you both for joining us today to this webinar. It was great talking to you and hearing from you. And thank you everyone for attending. We recorded this webinar, we will send it to you. I see that we also have some people that asking for our number, so we will contact you. And thank you. Have a great day and evening for the others.
Thank you for including us.
Thank you.
Appreciate it.
Bye-bye now.
Bye.
Bye-bye.